My dear friends, this is was my first clinical case with easy bone collector. First, I'd like to share here some small short videos I did. Just a moment. Today we will use this new technology, this smart instrument of Dr. Zastrow for bone harvesting. Easy bone collector. This is the instrument. You can see that serves for minimally invasive harvesting of bone shells from external oblique. The protector has to have contact with the bone and start. The next one is about 14, which absolutely enough for our result. And we have one additional shell to have more bone chip. You have a width about 14 millimeters. Because it mixed with blood, the white one is from extraoral spreading. Fully autogenous bone chip. Okay, this was just for impression what we did. And now I will start with presentation of this case. We discussed last Wednesday. We had this patient, female patient, which is young, with missing teeth in regular 1617. You can see this intraoral scan. There is some vertical component, but of missing bone, but we planned to do only resolve this case only with sinus floor elevation. And you can see here first, this video is from before the treatment. You can see here that we have into the sinus pseudocyst, retention cyst, and also we have very little height of the bone in the sinus floor. It varies, but it's at minimum 1 to 2 or at maximum to 4 millimeter, going mesially and distally. We decided to manage this cyst. First, we decided to approach the sinus with lateral approach. And when we get access to the Schneiderian membrane, first we planned to evacuate the liquid inside the cyst only by aspiration with a syringe and a big needle. And then we planned to do sinus floor elevation, implant installation, which in this case they were 4 by 10 stem implants. And then we will go to bone harvesting area at the right mandible. You can see here that we have double mental foramen. So we have to watch it about when we do the flap. And you can see that we had here a good donor site, which was appropriate for bone harvesting with easy bone collector. So as we discussed last time, we have to do proper planning. First, I did these three measurements, mesiodistally on the external oblique, so to have an idea where can place the easy bone collector and which direction, of course. I planned here 3 bone shelves. You can see if we measure with the slicing plane oriented vertically, we can measure the safety distance. We know the safety distance for EBC required large is only 4.5 millimeter. But is it so if we measure in this direction, the same direction, when we plan to insert the easy bone collector? Because we have to insert the easy bone collector in a right angle respect to the external oblique. So because the external oblique is not straight line, it is curved, and so we have to use different angle. But I realized that have to measure in actual direction which we plan to insert perpendicularly in the external oblique. So in the region distally behind 4.7, when we did this measurement with a straight slicing line, we had different measurements of the safety distance, and when we inclined this line as planned vector of introduction of easy bone collector, we measured less. This is because the tip of the easy bone collector will go more distally, and so will go mostly in the area of ascending ramus when the course of intraovular mandibular canal goes most superficially. So we have to pay attention about that. And so this is most mesial part of the third bone shell. We will meet here more flat or more convex, surface. So we have to choose also on the right vector.
And also was were the teeth an obstacle that you touched them with the protector?
Yeah, it is. In this case, actually not. I didn't interfere because the crowns of these teeth were not so big, but it may be. And also we have to plan where to start, not in this flat zone, maybe more apically, in order to have a good vector and to have good length of the, not to exit the donor side too early. And after that, when we watch the video, I will stop several times and will comment my mistakes I did. So, and this shows the situation after bone harvesting. You can see here that.
So, wait. Can you tell again?
Yeah, this is the situation after harvesting of 3 bone shells. So looking at the most distal one, you can see that I will go back. If you can see the most distal one, you can see that the angle we choose is not perpendicular to the occlusal line, occlusal plane. Yes, the line is inclined because the protector of the EBC bone collector has to be parallel to the external oblique, because if it is horizontal, so this distal part will meet too early this line, and the mesial part will be not fully inserted, and so this will result in a shorter bone shell than we expected. So if I stop here, you can realize that next bone shell is also in the I engage the external oblique in the correct right angle, but this differs from this vector, is different direction, and the last one is shorter. Was shorter because there are two reasons you can see after on the video, but one of them is choosing the vector from where to start. I think that I started a little bit more coronally than needed here, and so I was exit here too early, and this resulted in a shorter shell. And the other reason was that maybe I did some lateral movements before I inserted fully the EBC bone collector. So we had one preliminary fracture of the bone shell, and so it was also shorter. But it is learning curve, of course, and we have to discuss here everything we need and everything we are interested in order to have to use more properly the EBC bone collector. So now to the case. This is intraoral situation. I have this video here. Maybe in some I have to shorten a little bit because this video is about 30 minutes, but here it is not so interesting. Anesthesia, of course. Then flap design. We decided to install simultaneously with the sinus floor elevation 2 implants, and so I shifted a little bit palatally the incision. This helps me to have more better overview and more good conditions to insert the surgical guide. You can see that surgical guide has also this border palatal, which is holding the flap palatally. And then I planned also to use the surgical guide like landmark, like orienting points, and to outline the sinus window. These are 5 millimeter apically. Then I draw the lower border. The length, mesodistal length, was planned about 16, 17, I think. And then I decided to use burr technique. Maybe smaller burr I had to use because you can see that with this diamond I created bigger incision. Or any suggestions from your side? Maybe piezo device also is suitable, because my plan was to reposition this bone from the lateral bone wall of the sinus back at the end of operation. You can see how I did this at the end. So a little bit faster here. Okay, the wall was thin in the distal parts and not so thin in the mesial part. And you can see here I removed the bony window and saved it. You can see that the membrane was intact, Schneiderian membrane. And then next step was to manage the cysts by aspiration with needle, syringe and needle with bigger diameter. So in the first shot, I didn't succeed to locate the cysts. You can see, and then when after changing the position and the direction, you can see that I was able to evacuate the liquid from inside the cyst. The liquid was clear, a yellow liquid. That means there is no inflammation inside. And this allows the cyst just to implode and to reduce his diameter, volume. And I didn't try to remove the cysts, not in order not to create bigger perforation. I didn't worry about this small perforation with the needle. I did first, so by lifting the membrane, their dimensions reduced, so it's not a problem. About 2 milliliters, a little bit more of liquid. It's here. And then we started to lead the Schneiderian membrane. So I always start from the distal part, distal lower part, which is easier, and then go to the floor, and the mesial part is at the end. And there was no additional tearing membrane. Distally, there was present intrasinus crest, but it was not a problem. The membrane remains intact. So then we went to next step to install the implants. We had very little height of bone, so in the floor of the sinus. So I went only with the pilot drill, which was 2.2, and then I installed 2 implants with diameter 4 and length 10. And the pilot drill was enough in that case. If I did more, so maybe the torque will decrease significantly. You can see here that the torque first exceeded 40, but going more apically, it decreases itself about 20-25, and finally I had 25. That's because residual bone is not so much high. You can see here. And the 1.7 was the same, about 20, 25 final torque. And so we installed they had this position vertically about 1.52 millimeter subcrestally, because we don't want to have our implants superficially. And you can see here the Schneiderian membrane and the implants sticking out. And I know that some colleagues, they are doing these sinuses this way, only by repositioning the lateral window without any grafting, these methods. But here we decided to use shell technique, bone shell technique, especially here Semilunar Technique, and that's how we approach the site the same way, how with the regular blocks on the ascending ramus, then towards the middle of the crest, behind the last tooth for 7, and here we did some signs with surgical marker to have an idea where to start with the very distal harvesting behind the last tooth, last molar. And this was the ideal situation, and the first bone shell was the ideal dimensions. Also, the harvesting was very easy because the preconditions were ideal. We had a rectangular shape of the external oblique. We know the rules. We have to run first because before touching with the teeth of the easy bone collector, the bone surface, it has to be run. We use here 1/600 RPMs with abundant full irrigation, internal irrigation, and keeping the protector all the way in contact with the bone surface. Also applying here pressure with the finger on the head of handpiece, control handpiece. We apply axial pressure and run with the full speed. Here I stopped time to time because it's something new for me clinically, just to be sure what I am doing. Also, I instruct to my assistant not to be too close with the aspirator tips, not to aspirate all the liquid in order to have good irrigation, good cooling, of course, actually. And this was the first shell. I opened a little bit laterally, but the shell was in place, and I think this is the ideal situation. This was the first shell. Then I decided to go for the next one. We have to leave about 1 millimeter distance between first and second shell, semilunar shell, in order not to prevent sliding of the easy bone collector. So the second, you can see later that the second bone shell was not 17.5, but less. This is because maybe of the vector I choose. Also because of slightly oblique surface in this area. And the most difficult for me was the third shell. I used also here these orientations, landmarks like teeth, first most distal bone shell, the position of easy bone collector was distally, then next one, and the last one was in the front of the numbers 4, 6. You can see that this one remains into the easy bone collector, so we take it out with the pincet, and you can see the length. It's not the full length. And the third one was shortest one. I already say that I see for these two reasons. Maybe first a little bit wrong vector I choose to start more coronally than needed. I should to start more apically in order to have more longer vector in coronally apical direction. And the second reason, maybe this was a little bit inadvertent movement I did laterally, so I provoke this fracture. Can you see that? Because looking at the donor side, you can see here that for the first shell, I did some weakening at the base, so that not result with the shorter shell if the fracture line was more coronally. And you can see here the camera was not pointed at the right way, so you can not see the shells properly, but you have an idea already. And together the width of two shells is about 16 millimeters, so this was enough for us to cover this mesodistal dimension into the sinus over the implant. So my plan was to put two bone shells, of course after scraping, into the sinus over the apices of the implants. You can see here the donor side on the left picture. Seeing that picture, I think that maybe the third shell I promote preliminary fracture, so seeing that the base is still thick. What do you think about? Is this the reason or the vector?
I agree that I think if you would have placed the trephine slightly more apically,
yeah,
it would have been less thick. What was it a problem when you went down? That it was hard to go deeper, So it was like blocking itself, the
No,
trephine?
it
No.
was not blocking, but the lip of the patient was interfering with the handpiece. So I was to check. I changed the position, and so that doing that.
So were you sitting behind the patient? Did you have the handpiece like this, or were you like in front, like a pen?
Yeah. I was like a pen, maybe. Yeah.
Like a pen. You could have also like changed the position to go more in like a 12 o'clock position and then like pull it down here. No?
Yeah.
It's also possible.
Okay. And then next step, you can see here on the video, intraoral scraping. So I did here a mistake. Maybe I had to put inside the biting device. I forget that. And so the assistant was holding the jaw, but we produced so force, big force while scraping in the apical coronal direction, so the jaw is moving. And
He says you won't have any problem with that, Kaz. So don't worry.
Yeah.
With you won't have any TMJ problems. So that's don't worry. 90% of your patients are just fine.
I think the thought was just if it's less rigid, the amount of chips you can collect is less.
Yeah. When we do this motion from the apical to coronary, and also the jaw is moving together, and so this is not effective.
It's not efficient,
Not sufficient. Yeah. Well, if I put the biting device, maybe this will stabilize the situation.
Yeah.
Next time, I just forget it. When I do blocks, normal block, I always put the device, but this time I forget that, and so intraoral scraping is not so not so easy, not so effective, but we will improve that not only by instructing assistant to hold the jaw, because it's not so effective, but it's not sufficient, but biting device maybe will be better. Okay, and then the next, already scraped seminal shells. I will looking for appropriate position over the apex of the implant. So the length was enough, and on both shells was enough, the length, to cover the distance between the palatal and the lateral bone of the sinus. And also the width of two shells, they cover all the mesiodistal distance needed. And then this moment with fixation is a bit difficult to do. Is here the use of contra angle handpiece is unavoidable, I think. We cannot do this with the hand. I use here a 12 millimeter long macro screw, 1 millimeter diameter. Okay, just checking the stability. And the next shell. Next bone shell. These shells, they are naturally rounded, so I didn't do nothing for shaping and to round the edges, smooth the edges. Just put them inside. with one hand holding the shell into the sinus, and with the right hand passing with the drill. Also try to do this several times back and forth. You can see after a while. Back and forth, in order not to cause fracture while screwing into the bone shell. And then long screw. On the left here, these bone shavings, they are only for scraping of the bone shells, semilunar bone shells, outside the mouth. And the red one is from interoral scraping.
Your bone screw your fixation is going through the alveolar ridge just distal to the second bicuspid, between the second bicuspid and your first implant site?
Yes. There are
okay.
two fixing screw, one for each bone shell.
Okay.
For first one, and for the distal one, another one, micro screw. You can see that they are not perfectly aligned in a coronal apical direction, but they are over the apices of the implants. You can see here on the left picture the situation. So we create something like a box into the sinus. We have palatal bone wall, we have sinus floor bone wall, and we have a roof created with two semilunar bone shells, and the lateral bone wall we reconstruct by repositioning of the from bony window. We don't have bony walls, only mesially and distally. And then grafting with only autogenous bone. I mixed these two portions from extraoral and from intraoral scraping, and then start to graft in the space. Maybe I had to give a little bit more higher position of the bone shells to make easy bone grafting, because the opening is here was not so big. But anyway, I think I will not worry if I have some empty space underneath, because it is a box and then we have blood clot inside. Now trying to put the chips from distally. And this is on the left after grafting with all the material we had. And after that, repositioning of the bony wall, lateral bony wall. Of course, it is not coincide because my burr was a little bit bigger than needed. But I decided to fixate it to the lower border and to have the gap on the apical. Which is was not my grafting area, apically. It is over the bone shells, over the box, and glue it. Do you sometimes periacryl, this cyanoacrylate glue? I used it for the first time, but I think it works well. You can see the stabilization. And
the sinus wall you put in the same place again, right? You just put it back.
Yeah. Yes. Yes.
Sinus window you took out before. Great.
And the gap, which remains apically, which is not floor elevation, which it is just sinus, over the augmented area, I just fill it with CGF membranes, autologous CGS membranes. In order to have more stable situation, also to have more growth factors in the area. And this was in the left after stabilizing the bone wall and remaining gap apically. We grafted with stabilized the area with zone with only CGF membranes.
What is CGF again? It's like PRF?
Yeah, it's the same, just different company. From autologous.
How did you stabilize the lateral wall?
How I stabilize the lateral wall? Only with
you put the lateral wall back, the piece of bone you removed for the lateral wall of the sinus when you started?
Yes.
Did you put it back?
Yes. Yes.
And did you stabilize it with
no
screws?
Only with glue. I glue.
Okay.
With cyanoacrylate glue.
Very good. I'm sorry. Missed that.
And this is after putting inside all the membranes we had. You can see here 2 implants subcrestally placed, 2 micro screws, 12 millimeter long, going parallel with the implants and stabilizing the bone shells. which from one side partly are over the apices of the implants, and laterally they are with fixed with micro screws, and then the reposition of the bone lateral bone wall from the window, gluing it only, and then CGF, and of course suture.
You have to spin to get that CGF membrane, Kraz.
CGF, yes, CGF from autologous block.
But
Lot.
how much?
How much?
Fancy.
Eight.
Thank you. I don't use it, but I'm thinking about it.
Yeah, I use from many years.
Yeah, I
I'm
know.
every no when yeah.
Every page, yeah.
And you can see finally the control CBCT at we did at the same day of operation, after operation. You can see here on the sagittal view, you can see, sorry. You can see fixes, screw, implants, and here is the first bone shell, and here is the second one. Can you see this semilunar shape?
Yes.
1, 2. And they create a roof over the implants and protect the graft against forces produced by breathing patient. And again, here on the coronal view, you can see here the bone shell over the distal implant, 1/7. This is the bone shell. And when we going more mesially, this is already the first bone shell. This is present the length of the bone shell here, which is reaching the palatal wall of the sinus.
That's the beauty of it.
You can see
exactly how you planned it. That's so amazing.
Yeah, the gap remained is not so big in the pictures. In clinical pictures, looks like to be very big, but this is the gap only remained. And here on the axial view, you can see the reconstructed bone wall, lateral bone wall of the sinus. And again, here the donor side with 3 bone shells. And that's it. That's it, the case.
Just amazing. Really, congratulations. I'm really happy that you also had a good experience now with the Semilunar Technique. And yeah, but also, yeah, so you're very critical, which is good. And look what could be improved. So some learnings regarding the angle, and that's, yeah, that's how we should approach it. Very scientific, yeah.
Every time we have this learning curve to go through it, and so it's not the way how to way around.
No way around, yeah.
No way around, yeah.
No, but it looks so nice also now to see the harvesting site. So right to do CBCT afterwards. That's also very exciting, I think.
Yeah, because I wanted to answer myself many questions I had, especially here in the planning of the pre-planning of the donor site. So you can see the anatomy varies here, also double exit of the mental foramen, which matters when we plan the flap or vertical incision, not to be here. And also the length, but I need more cases to get more experience with donor side with these bone collectors. So
Also to see how it looks like after 1 year, right? That's also super interesting.
which
And
one?
we control CBCT, how the harvesting side looks like then. If it's
It's amazing that the harvesting side with you can see here, yes, that we engage only the cortical bone. So
yeah.
that I expect here in this patient to have less swelling compared to other cases.
Can you scroll through to see everywhere how deep we went with the trephine? That's actually also interesting, yeah, as you said. So it's supposed to take mainly an intracortical shell, yeah. And I mean 2.2, if you used the large, right? 2.2 millimeter thickness,
yes.
Plus 0.4 millimeter, yeah, 0.4 millimeter metal part. So we should go not deeper than 2.6 millimeter into the bone, yeah. And it shows exactly that the sponge's bone is never opened, yeah.
Yeah. We didn't open at all the sponge.
Wait, let's also...
We left also some thin cortical layer here.
Exactly. Can you scroll through it and also maybe you say some words that it's an intracortical shell?
Yes, this is intracortical shell that differs from harvesting of the normal cortical block because here the line goes only through the cortical bone, and also you can see that left some thin layer of cortical bone intact. So we didn't promote any bleeding from the marrow, underlying marrow. And that's it that we expect to have less swelling in this case. Just have to understand vectors. For me, the main question here is to understand vectors, how to choose the vector, when to start, which inclination, and we know that after choosing once the vector, we cannot change it. So we have to pre-plan in very good way, in proper way. Not to have shorter shells than needed. The third shell here, I harvested only for that reason, that to have more chips, but also to get more experience with estimating the vector. But in this mesial area is more difficult to estimate how to choose the vector, because this in the mesial part it is convex structure, and so we really have to enter with the easy bone collector more apically. Just my feeling is so. I'm still not experienced with this instrument, but I feel this. That is it so, Frank, or not?
Yeah, absolutely. No. I mean, how you approach that, it's fantastic. Yeah, I told you already last time. So the way how you're doing the planning, and that's very important. Yeah, to do a proper planning. Yeah, not to take any risk for the nerve. With safety, know what is possible. Yeah,
especially in this case, we have zero risk for the nerve, because the maximum thickness is 2.2. We never can reach whatever we do. We cannot reach.
Plus the metal part to 0.4. So we always have to add that, or to put it
Of
together.
course, but we have here huge safety distance.
Yeah.
Yes. Another question is here, are we able to harvest the dimensions of bone shells we needed? Because we have here mainly 2 shots or 3 shots. And if we make mistake, maybe we will not able to have good shells. Regarding to the time needed, of course, the time was reduced dramatically compared to the normal block, because we don't need it to split it, to round it, to give a right shape. Also, I think when we get used already, the time will reduce dramatically needed for operation time.
I mean, also with the recording and with the documentation, the picture and everything, probably it also took some more time, right, for you. But if you would have measured only harvesting without stopping too much, what do you think? How long would it have taken?
I have still not did that. Didn't measure the time, but I can measure on the video, of course. In this particular case, we had to manage here the sinus, the cyst, and so it was
of course,
long time, of course.
Many different things, yeah.
Also doing pictures, videos. This also time, extra time.
Yeah, of course. Really, really nice. Beautiful. Questions from the colleagues. Daryl, something.
Oh, I just well, I had to keep on going in and out, but yeah, Kraz, that's pretty amazing. I love the way you troubleshooted, and yeah, I think the vectors and how we're going to use the easy bone collector for sure to make sure that we get the most shell out of it, because we got really 1, 2, or 3 chances in the area, or it's like or open up on the other side.
Only 2 shots allowed.
yeah, it's all we need. So yeah, I can't wait to start using mine when I get it, when it happens. But yeah, beautiful documentation, and I like the way you did this with just using it to more just raise up the sinus membrane. It kind of reminds me of the training I did, but of course this is a lot better when with Giesenhagen, with the bone ring technique, when he's putting the bone ring within the sinus and placing the implant. That training was very interesting when I did it. We did it on cadavers. Never had the pleasure of actually taking a bone ring and putting it in the sinus and doing it, but I was able to successfully do it on the cadaver in a course with a bunch of oral surgeons who couldn't do it. So that kind of made me feel kind of happy.
Did you ever try it at the patient? Probably not, right?
No. I did a total of 4 bone rings. No, 3 bone rings, and knock on wood, they're all still holding on. I did before I met you. I also did 1 vertical augmentation with that Augma cement, bone cement from Israel, and believe it or not, that one actually after 4 years is still holding up. So we'll see. Still not autogenous. So go to autogenous. But anyways, but I have to run. I'm off to San Diego tonight for the Neodent convention. So I'll send you a picture from Mr. Ace, Frank.
You're giving lecture or course?
No. I'm not giving my course is next weekend. I'm just going to be hanging around with a lot of the oral surgeons. So a lot of surgeons that train Dan. A couple of them that are lecturing there. So it'll be very interesting. It'll be fun.
Make
So
some friends this time, okay, Daryl? Don't
Hey.
get those oral surgeons mad at you. Jeez.
I don't care. I actually all I am is hanging around with oral surgeons actually.
Okay, good.
The only oral surgeons that are going to get mad at me are the ones that are around here.
Yeah, you're local.
In
You're
my local
guys,
area,
right?
Yeah, but not the guys that everywhere else. They're cool with me because I'm not their competition. So
Yeah.
which is so sad because there's so much business in the area. I mean, there's 800 general dentists in my vicinity around a 20-mile radius.
Wow.
And they're worried about little old me.
Yeah.
Whatever. I don't have time. Let's all do good work and help people. That's what I like to do. So,
It's all good.
all right, man.
Great.
Everybody have a
safe
great
trip.
week. Thanks,
Take
Kraz,
care,
for showing
everybody.
it. It was
Bye,
amazing.
Daryl.
Frank,
Kraz, thank you
Dick,
so much for that
everybody
excellent
else.
presentation. Details.
Details. The devil is in the details. There you go.
Yeah.
Of course. Yeah.
So
All right.
nice.
Bye-bye.
So nice,
Bye.
everybody. Take
Hi,
care.
Daryl. Really beautiful. Yeah. Any other questions from the colleagues?
No, always a pleasure to tune in. But yeah, as the farther, Kraz, I think the farther you come anterior on that mandible, the thicker that apical border of the mandible becomes, and just it's just a different vector, as you say. You start off on the top, but it's getting thicker. It's getting thicker as you go down. There's nothing you can do about that except maybe like you did on the first one. You made a cut, at the apical border of your trephine, at the depth of your trephine. You make an apical cut so it doesn't break off like that, because it's with the same vector. It's getting thicker in that area. I don't know if we go to the CT scan and look at it in an AP view, whether we can see how that
That would be
looks.
actually interesting. That would be interesting. Yeah, how deep we went now into the bone. So if we went
Yes, just the way
deeper,
it broke off when he showed it, it looked like it was thicker than the other areas at that same
Yeah.
point.
I will try to open the control CBCT. Just to wait a little bit.
Yeah, very interesting.
What do you want to see here? Maybe the other side.
mesial shell, exactly. How deep we went here
Exactly. Yeah.
into the bone. What was the maximum depth when we look in the right angle? Probably, I don't know.
Amazing.
Maybe we can use the same angle like the cut again, that we see like a
Yeah.
cut, and then we can measure maybe the distance if we see like a straight.
Just a moment to see how to do it properly.
Maybe in the right lower picture, yeah, or there maybe.
Yeah, but we have to orient
Yeah.
first the line to be.
Yeah, exactly.
And then we can go a little bit back and forth. You want to see the first one.
Yeah, right.
Yeah.
Right there, and then go apically, or from coronal to apical.
Yeah.
Or just look at, just go to apical and see the depth.
Coronal staple here. This is the most apical part. You can see here.
It's getting thicker in that area than it is at the
here.
Yeah.
Here. But I think I had to choose my vector not like this, just
Yeah, no, the tooth wouldn't let you
can
choose
draw,
that vector.
I can draw.
Yeah.
Color. I choose this vector.
Yeah.
Oh, sorry. It's not the right. It's not the right. Place. I choose this vector. I started from here. This was my entering point. Can you see? But I think that I should choose maybe not so coronally, but enter here and to catch this vector.
The undercut slightly.
Is this right? Does it make sense or?
Yeah, to me it makes sense, yeah. Or at least a little bit more. Maybe
Yeah, it's more just to
more,
understand.
more towards that direction, yeah.
Of course, just to have the idea and to get the difference.
Yeah.
Regarding that, this means we have to have good preparation of the flap until the border of the mandible. We have to see the border when we prepare the flap, after preparation of the flap, to have this ability to sync here the instrument more apically. And in these zones, more mesial zones, when we approaching the external oblique, maybe we have to start not from this level here, but maybe a little bit more apically and more like this direction on the left picture, green line. Also not to do inadvertently lateral moving of the easy bone collector before its fully insertion. So not to promote the fracture line here too early.
What do you mean lateral change? Did you went out with the easy bone collector? No.
No. I was so, but I just rotate to change the position by rotating of the handpiece because it was interfering with the lip of the patient. And so while doing that, maybe I did inadvertently lateral inclination.
And then you caused fracture beforehand.
Yeah.
Too early. Okay.
Maybe this the main reason here. Also the second reason, choosing the not so appropriate vector.
No, but so nice case. I'm excited and I'm glad to hear. So when is the next case coming?
Next case. I plan one patient, but we just talked yesterday with her. It's small case. Yeah. If she get agreed, it's lower 3/6 with small lateral augmentation and simultaneous placement of implant. But we'll see if the patient agree.
The program you have, Krasimir, Implant Station Beta, is it available all over Europe or?
Yes, it is.
Okay.
You can download from their official site, Implant Station site,
Yes.
It is free of charge. You can use it. Just only when you want to do exports of guides, you should buy here exports. If only viewing planning, it costs nothing.
It seems to work very well in your hands.
Yeah.
I used already. I like it because it works only on Mac computer, so
Yes.
it's convenient for me.
So Krasimir, if you want to make maybe like a nice post with some videos and some nice pictures, that would be amazing. Just tag me and I will repost it. So I think that will get a lot of likes.
Yes, I will do. I will do that.
Beautiful, beautiful. Yeah, slowly the cases are coming in. I'm really glad to see. There was another colleague joining another live call, but he just did the case. He was facing some problems, so that the shell became too short. So, but he wanted to provide also the pictures. I think he also did that mistake that he came out too early of that angle. So if he would have some more pictures or something, then we might look into that. But he didn't join now. Probably he had patience, so maybe he's coming back. Yeah, maybe now the next call or next week. So yeah, of course, it's still not super easy, right? I mean, you still have to have some skills. You still have to follow some guidelines, but more recommendations we can give and the better guidelines also regarding planning, the better it is for everyone. And the better will be the results. Yeah. Also learning curve. Yeah. So once a colleague did like a joke, or I don't remember if it was me, so that maybe in the future all the jaws might look like that, like a waveform.
Like this here.
So the new normal.
And then, you know, a million years from now, when they're digging up the bones and the anthropologists are
What
going,
happened there?
you know, what happened with this mutation that everybody has the wavy jaws?
Exactly. Funny.
Yes. Thank you, Kraz. I have to go, but it's always a pleasure to see your presentations. I'm in awe of the detail and the documentation every time I see it. And the skill too goes without saying, but fabulous. Great. Glad I tuned in today, and take care, everybody. Have a good week.
Thank you for attending, Kim. See you next time.
My pleasure.
Bye-bye.
Take care now. Bye-bye.
Bye.
Yeah, that's interesting. Yeah, can you scroll through the left again? That's interesting.
You can see here 3 shots.
Yes. All intracortical shells.
Yeah. And also the distance between them.
Yeah, little bone peaks in between to ensure support of the protector.
Only intracortical.
Beautiful. Beautiful, beautiful. So the baby is born. Came to stay.
We're expecting our next cases.
Absolutely. Good. So let's jump into the other link, and let's see if someone's attending. So I'll see you there in a minute.
Yes.